Good morning, everyone. Can I have your attention? Okay. It's lovely to hear that buzz of conversation and everyone catching up with each other, and fantastic to see this great turnout here today. I'm Katrina Crowe. I have the privilege to be the chairperson of the SAIL project, and I want to welcome you all to our symposium on the inspiring idea of recovery and the launch of RecoverMe, which is SAIL's new wonderful resource that we want to share with everybody dealing with that subject. But before we start, there's a video on the housekeeping issues like mobile phones and exits, which our technical manager will show you now.
Ladies and gentlemen, may we please have your attention for this public safety announcement. This is the main conference hall. The conference hall has 3 emergency exits. Exit signs will remain illuminated at all times. Please take a moment to check the exit nearest you, bearing in mind that it may be behind you. In the event of emergency, you will be asked to proceed to the exit and move up the stairs to the assembly point located in the lower castle yard beside the church. For your convenience, restrooms are located outside the main entrance to the room. Please ensure that mobile phones are switched to silent while in the conference hall, and remember that Dublin Castle is a no-smoking building. If you are using headsets, we would request that you return them to where you found them when you have finished. Welcome to Dublin, Ireland, and at its heart, Dublin Castle. For over 800 years, Dublin Castle has been at the centre of Irish political and cultural history. Please take time during your visit to tour around the castle, see Ireland's past in pride of place and memory, and enjoy the breathtaking art, furniture and decor. Thank you for your attention and enjoy your time in Dublin Castle.
That might be there. The SAIL project is based in Amiens Street in Dublin, in the heart of the North Inner City, which remains to this day one of the most marginalised and deprived areas in the country. It's a rehabilitation, education, advocacy and personal development project for women with addiction issues. We have passed well over 300 women through our doors since we opened them in 1997, and we expect to be continuing to do that with the help of our funders, the HSE and the Probation Service and FÁS, for many years to come. Our success rate is very high. We have an extraordinarily dedicated staff who absolutely devote themselves to the welfare of our participants. And we also have wonderful participants, and some of you, I hope, have seen the beautiful photographs that we have in the lobby out there, which were taken by Ray Hegarty but designed by our own participants themselves to tell their own story. I think they're incredibly moving, really beautiful, and something we're all very proud of and that they should be very proud of. So today we are launching yet another fabulous resource that's been created by our staff, RecoverMe. It follows on from Reduce the Use, which was the resource that we developed in response to the cocaine epidemic, for which there was no, if you like, surrogate. In the case of heroin, obviously people can take methadone, but for cocaine there isn't any surrogate. So this was a resource that we built based around cognitive behavioural therapy principles and community development principles, which inform everything the project does, to try to help people deal with addiction to cocaine. It's been hugely successful. It's now being used in many projects all over the country, and we expect that the same will be the case for RecoverMe. So to launch that and to open our morning here, I'm delighted that we have with us Alex White, Minister Alex White, who's Minister for Primary Care at the Department of Health and also for the National Drug Strategy. Alex has been a really good friend to SAIL for many, many years. He was on our board for a long time before he became a TD, when of course he had to leave it. But he's always been available to us with wise advice, particularly on legal matters when we often very badly needed it. Great friend to the project, as I say, and we're thrilled that he's here today for us. As some of you may know, he's engaged in a serious battle for the leadership of the Labour Party at the moment, and he's going to be rushing off to deal with that as soon as he's finished here, and I'm sure we all wish him the very best with that. Alex, if you wouldn't mind launching the resource. Thank you.
Thank you very much, Katrina. Good morning, everybody. I'm absolutely delighted to be here this morning at Dublin Castle to launch RecoverMe. But can I, at the outset, thank Sales Project Director Gary Broderick and, of course, your Chairperson Katrina Crowe for inviting me here to perform this launch this morning. I'd also like to welcome today's keynote speakers, Professor Melinda Hohman from the University of San Diego, Dr. Hilda Loughran of UCD, Dr. Paul Dalton of St. Vincent's University Hospital, and of course Barry Costello of the SAIL project. I had a few minutes just before we started, as Katrina said, to meet some people outside and also to view the photographic exhibition. And I want to just agree with what Katrina said about what's been achieved. A really terrific set of photographs, beautifully produced, and so moving and affecting to see what people have achieved in that work outside. And I'd like to congratulate, of course, in particular, the women who participated in that project, and also the project, me, myself, I, and also Ray Hegarty, whose work is, as I said, outside on display, and it's really well worth just pausing for a few minutes at the coffee break or otherwise during the day to see what's been achieved there. It really is exceptional, really exceptional. As some of you in the audience will be aware, and as Katrina mentioned, I have a personal connection with the SAIL project, having been a board member for a number of years prior to my entry into Leinster House and appointment as a minister. As a result, I'm very, very familiar with the terrific and really vital work that the SAIL project does in providing a recovery facility for women with addiction issues, at the very heart, in the very heart of the city, the North Inner City, and relating to, obviously, the broader context of the North Inner City Local Drugs Task Force. The SAIL project creates positive, meaningful change in women's lives through an integrated programme of education, rehabilitation, advocacy, childcare provision, progression, and of course aftercare supports, extremely important. Following on from the success of the Reduce the Use 2 programme, with its worksheets apparently having been downloaded something like 6,000 times, it was clear that people who completed that programme found it incredibly valuable and wanted more. And I would like to just pause and again pay tribute to SAIL and the workers in SAIL for the outstanding work that they're doing in relation to developing this manual and developing generally the work. Because, you know, people who are busy in the day-to-day preoccupation of their own work very seldom have time to devote to expanding out on that work and the achievements and the learning that they've got in their day-to-day work, to share that with others, to share it with other projects around the country, and to make it available to other people in other parts of the country and who are engaged in similar work. So I think people really need to be congratulated and commended for not just doing the work that you have to do from day to day, but also looking to see how can we improve that, how can we enhance that, how can we deepen the kind of learning that's there, and most importantly of all, how can we in a professional way share that with others who have similar demands and similar interests. So I think SAIL really stands to be congratulated on a lot of different scores and counts, but in that area of actually being available to share your work, your insights, your ability to train others and bring others into the picture, I think that's an especially impressive achievement of SAIL, and I congratulate you for it and everything that you're doing. The RecoverMe has been born out of the, as I said, the success of the Reduce the Use 2. It's a new programme, as you know, that's why we're here, designed to guide people in discovering one's own feelings and to understand far better, maybe, how one's own feelings and how our own feelings are impacting on our recovery. Helping people manage their feelings in an empowered way is really, I suppose, the key to recovery and to avoiding slips and avoiding relapses. RecoverMe is a 12-module program based on motivational interviewing, cognitive behavioural therapy and mindfulness. The approach taken by the RecoverMe program is consistent with the National Drug Strategy's actions on recovery. Indeed, its development, I feel, is timely and contributes to a wider conversation, which I sense is gathering some momentum, about how best we can understand recovery, and the need to holistically capture all human experiences within the recovery model. I was also very impressed to learn that the SAIL project has already piloted the RecoverMe programme at Áras in Kildare, the Ballyfermot STAR project, the Ballymun STAR, and the Coolmine Day programme. Having visited both Coolmine and Áras in Newbridge, I have shared at first hand the outcomes of the really marvellous work that is being achieved there. These organisations have provided constructive feedback. They provided new ideas and learning, helping to create the final RecoverMe manual. So again, this is a strong example of that often elusive requirement that we hear about, joined up thinking and cooperation and collaboration, which is really manifest in this achievement here with this manual that we're launching today. So it's no surprise to me to learn that RecoverMe scored consistently highly in terms of relevance, confidence building, improving relationships, increasing optimism, influencing communication skills, and increasing desire for change. I think it reflects especially well on the SAIL project, if I may say so again, and on RecoverMe, just like other programs that this manual and these supports will be available free, online, on the SAIL project's website, which is a fantastic resource and wonderful that it will be accessible free of charge. I'm pleased also to see that training in RecoverMe is already scheduled for the autumn of this year. So it's just been an immensely impressive piece of work, put together with great care and skill and professionalism. And I just want to once again congratulate you for it. I do very much hope that you'll find today's workshops on exercises contained in the manual helpful. I want to thank the SAIL project for inviting me here today. I would love to stay. I genuinely would love to stay and hear the distinguished speakers and also participate. But unfortunately, I have one or two other things that I do have to attend to, so I can't. Maybe I'll find out from others who are here about the success of the day, and I'm sure it will be a terrific opportunity for everybody to engage. I want to again assure you of my continued support and to wish you well both today and in the future with your critically important and innovative work. Thank you very much indeed. And I should actually do what I was asked to come here to do and formally launch the RecoverMe manual. I declare it now launched. Thank you very much.
Thanks, Sonny. Yes. Thanks very much for that, Alex, and we were absolutely delighted to have you here today with us. Now, we have a distinguished slate of very interesting and informative speakers here this morning. I'm very much looking forward to hear what they're going to tell us, as I'm sure all of you are. But before I go on, I just want to thank Alex again, who's just now gone, for getting us this beautiful venue, which normally costs thousands of squids, and we managed to get it for nothing, or nearly nothing. This is the ingenuity of the SAIL project, make do with what we got. But it really is lovely to be in Dublin Castle, isn't it? It feels like the appropriate setting for where we are. Our first speaker this morning is Professor Melinda Hohman, who I've just had the pleasure of meeting some minutes ago. She's professor at the School of Social Work in San Diego since 1995. She's an expert in substance misuse treatment, motivational interviewing, and social work practice. She's got a particular interest in treatment services with women, so she's an appropriate speaker for something run by the SAIL project. She published Motivational Interviewing and Social Work Practice in 2012, and she speaks today about the history of the recovery movement, so setting a context, if you like, for where we're going further. Melinda, if you'd like to speak at the other platform.
Thank you. It's wonderful to be here. Make sure this microphone is working and we're all set and ready to go. Is it working? Okay. Bend it down a little bit. I want to thank Gary for inviting me to speak here today. This is a very exciting opportunity. I have been here for the last 2 weeks. I am leading a group of 18 social work and other helping professional students from San Diego State. If you could raise your hands and show you to the audience. Okay. I'm fortunate to have a group of 18 women who are interested in addiction work as well as learning about Ireland and the Irish culture. And we've been doing a little bit of both during our last 2 weeks here. And this is such a special treat for Americans to be able to come to the Dublin Castle and to see this beautiful venue, and as well as participate as if we were practitioners in your own country. So thank you for your generosity of inviting us and inviting our students. And Gary has also offered that some of our students will participate in the demonstration breakout sessions afterwards. So they're very excited to be able to do that. Of course, my views about recovery and addiction work come from an American perspective, so I'm sure you'll all realize that and keep that in mind. I do know a bit about the Irish perspective, having led students here and visiting Sale and Coal Mine and the drug courts and some of the different programs that you have around town. What I would like to do today is take us down memory lane, and I really had fun putting together this presentation to look at what is the recovery process and how have we learned and developed our knowledge. My background is as a substance abuse counselor, and now I work as a social work educator teaching about substance use and substance use treatment. Okay, got the clicker. All right. So thinking back to where we come from in terms of our history around addiction work. Prior to the 80s, people would go for treatment. Usually it was, at least in America, 28-day stay. You would go in, and then when your treatment was over, it was goodbye, out the door, go forth and stay sober. There really weren't any services to help people. There weren't any kinds of thinking about perhaps there are other unfinished issues and concerns. The thing is, if you've got treatment, then you should be able to go back to work, or you should be able to find a job. You should be able to resume your role back in your family. It's now that you are clean and sober, there should be no more problems. This was really based on a social support model. People were sent on what was called a 90 and 90, go to 90 meetings in 90 days to attend Alcoholics Anonymous, Narcotics Anonymous, but that was where people were expected to find their support. Again, we didn't really talk about any of the lifestyle issues around family concern, employment, mental health. It was just you go use your meetings and do what they tell you to do at the meetings, get yourself a sponsor. And AA talked about you have 3 things to do, which is to change the people in your life, your places, and your playgrounds. If you do these kinds of things, all will be well. And if you did use under this model, it was considered a relapse. And there really wasn't anything, resources to help people in this situation other than to say you need to go back to your meetings and rework your program. So the thinking was as long as our clients stayed clean, all was well. We had done our job as professionals then, and people who were in recovery themselves, staying abstinent, all was well. But people started to realize that that really wasn't necessarily the case. It was in 1978 that recovery as a distinct process from getting someone clean or getting sober was identified. And some different kinds of models came out of it, and we'll look at what those are: cognitive behavioral models, developmental models, and combination models. So let's take a look at what some of these are. But before we do that, I wanted to discuss the slide about innovation. And this is, anytime there is an innovation in society, some researchers have found that it goes through a certain process. And think about your use of mobile phones. How many of you remember the big old ones that were like in a box, like this big, and you carried them in your car? And over time, they've gotten smaller and smaller and smaller, and the technology's improved to the point where almost everyone, and I'm not sure of the usage rate in Ireland, I know in the United States it's something like 90-some%, people use cellular or mobile phones. And so when you think about an innovation and how it gets disseminated into our cultures, see how this works here? What they talk about is initially you have what are called the innovators, people who have innovated something and start to use it. Then we have what are called the early adopters, people that see what has been innovated and say, oh, this is really interesting. I think I'm going to learn about this or to utilize this, to take this as part of my work or part of my lifestyle. Then we have the early majority, late majority, and then the laggards, the last people. And probably some of you know people that are still saying, there's no way I'm ever going to have a mobile phone. Not too many, but there's people with that. But at some point, you have almost 100% of people have at least adopted this innovation. And why I included this slide was to think about not every addiction professional treatment program out there really jumped on the bandwagon right away about thinking about what is recovery. It's been a slow process. So it typically followed this model that some people jumped on it right away and other people were very slow to adapt it. And as we'll see how that happened, one of the first books to come out, and really is at this point we were focused on what was called relapse prevention. Okay, we've gotten the person clean, but let's think about relapse prevention. And it was beyond just going to AA and working that program. And Marlatt and Gordon were two researchers that developed a cognitive behavioral model. It was really one of the first tools on recovery. And I worked with an outpatient group just peripherally, and they were what I would call the early adopters. They started offering a relapse prevention group based on Marlatt's model. And to me, I attended this group so I could learn what they were doing. And it was talking about behavioral kinds of concepts. Oops, my slide kind of moved there. But Marlatt and Gordon introduced different concepts that we had never considered as addiction professionals. And the one concept that it moved up there is called the determinants of relapse, to help people think about if they used substances while supposedly, again, this is coming from an abstinence-based model, what happened? How did that happen? That someone just doesn't happen to use, that it really is part of a process. And they introduced the idea of functional analysis. And many of you who are clients in this room, as well as therapists in this room, know that a functional analysis is where you sit with the client, or as the client, you think about what have I used, how much do I use, what is the context. It's to really break it down and break it apart. And the functional analysis helps clients, and it helps counselors, therapists working with them, to understand maybe that little bit of what happens before the actual use occurs. And, excuse me, Marlatt and Gordon developed this technique called relapse road mapping, which is basically where you physically draw out what happened. So you're thinking about, I was feeling lonely, I was feeling bored, I called my friends, nobody was around, I started looking for my using friends. My using friends were at the local pub. I went down to the pub, I thought, I'll be fine, I won't drink anything, I'll have a Coke, Coca-Cola, and then drinking happens. So what kind of happened? And at this point, they worked on tying it back to perhaps some of those emotions and those feelings around being lonely, bored, feeling isolated, and then starting to have the cognitive thoughts about, I need to be with my friends. But picking friends who are active drinkers. And he called that seemingly irrelevant decisions, like making decisions that we don't think has any kind of impact. And when you think about, it's not just substances, this could be around other types of behaviors too, where people are trying to avoid, that we still set ourselves up and put ourselves into situations where then we wonder, how did this happen? So he worked on helping clients think about these seemingly irrelevant decisions. identifying high-risk situations, and this whole focus on what he called outcome expectancies. When you have a lapse, does that mean then your sobriety, your abstinence, your recovery program is done, or is it a relapse, or is it a lapse? Like, time to look at this, look at what happened in terms of my recovery process, and refocus myself. So the book is a lot about cognitive factors, how we think, how our clients think, helping them think it through, as well as then the coping kind of skills behavior. And in many ways, the recovery model has taken this and extended it even further. Another one that became very popular, at least in the States, was developed by Gorski and Miller. And this seemed to be more readily adopted by the 12-step type of treatment providers, at least that were operating in America. And I would note that that's still predominantly the model of treatment in the United States today. The harm reduction model is still less used, and it's based on a number of reasons culturally in the United States. And it's been exciting for me, with my students, to be able to look at agencies that are using harm reduction and to discuss the various aspects of it, and to think, again, the early adopters outside of the box. Gorski and Miller developed what I'm calling developmental models, as well as a woman named Stephanie Brown, who interviewed, I think it was about 150 people in recovery from alcohol use, and she identified that people went through various stages. She called it transition, early, and ongoing recovery. Gorski and Miller's model was very similar. He discussed early, middle, and late recovery, and talked about how there's different tasks and different things that people have to work on. And he also identified something called post-acute withdrawal syndrome, which was based more on his experience than research, but many people identified with it, which was what happens once you quit using, and some of the physical as well as the psychological effects. There was a lot of discussion in the treatment community in the United States around this model, and thinking about, are there different tasks for different stages? And some of the thinking was that in this first stage, and Gorski very much promoted this, that you dealt with your addiction, and you dealt with learning how to live in abstinence. If other issues arose, mental health issues, gambling problems, sexual addiction, those kinds of things, they were dealt with later in middle and late tasks of recovery. And many treatment professionals disagreed with this and said it all has to be worked together at the same time. But there was that ongoing debate. But Gorski and Miller's model was more widely embraced by the treatment community. So going back to look at our innovation adoption model, at some point the language started to change, and I don't know if this has ever been exactly identified, from relapse prevention to recovery. So the focus became more on not just we're going to keep this person clean or sober, but we're going to help them in terms of their recovery. So early research, and Dr. Loughran's going to talk about evaluation, but early research of addiction work focused on the number of days people stayed abstinent. That was your measurement of outcome success. How many people are actually clean and sober out of all your clients? And treatment providers, as well as our own federal government in the United States, started saying this is not enough. We have to look at quality of life indicators, such as how many of your clients are actually employed, how many clients have stable housing, what percentage of clients have had no further arrests. So we started looking at, it's not just enough to measure how many days has that person stayed clean, but really looking at how has their life improved. Because many of you who are clients, and those of you who are professionals working with clients, can attest to staying clean for many people is just not enough. People are just hanging on by their fingernails. And so we really started looking at how do we help people either put their lives back together or gain the life that they never had, that they want. So as the innovators changed and the adopters changed, and many people were getting more with understanding that it's not just enough to treat someone and then push them out the door, that we really need to focus on the recovery process. Another interesting developmental model that became widely adopted and has been very well supported by research is what's called the matrix model. And part of this came out of the cocaine epidemic in the United States. The Matrix program is based in our neighborhood near San Diego. It's based in Los Angeles. And they also developed a developmental model where they identified distinct stages for clients who are trying to be abstinent from cocaine, and really identified almost the time period. And as you can see in this model, they had withdrawal was the first 2 weeks, and then they talked about the honeymoon stage after people go through withdrawal and were abstinent and feeling like this is great, I can lick this, I don't need cocaine. And then they identified, which was very important for treatment professionals, a stage they called the wall, that people slam into this wall at some point during the second, third month, fourth month, in terms of feeling like this is too hard, I'm having depression, this is too much of a struggle. And while I am not a neuroscientist, I would venture to say probably some of this has to do with the neurochemicals in the brain readjusting themselves. And so it became very important for people working in this model to be highly vigilant with their clients during this, that the clients are coming off the honeymoon and feeling happy, but realizing that as counselors working with clients and warning clients to expect this to happen to you, then this is a normal part of the process to feel terrible and to feel like you're giving it up and to say, why am I bothering doing this? Then they identified an adjustment stage, 4 to 6 months out, and then what they called a resolution stage. So in their model, they have various interventions that are tailored to each stage of the recovery process. Take a quick break. And this one is a little hard to read, but we started also focusing on what is the role of recovery and how does culture play into that. And this was a piece that I worked on where I interviewed women who were mainly Mexican or Mexican American, mostly Spanish speakers, which we have a high population of in San Diego, who were residing in a recovery program specifically geared for Latino women. And to understand some of the contextual, cultural factors that go into what does it mean to be a member of a particular group and to work on recovery issues. And in this situation, alcohol and drug use is highly stigmatized within the Latino community for women. So for a woman to identify that she had this problem took a lot of guts. Typically families in the Latino community tried to fix this and deal with it and not want to go to agencies. Many times agencies in the United States are seen as white agencies. So for minority clients, it becomes very difficult. I would imagine some of you could get up and speak to some similar kinds of situations here in Ireland. But we started looking at how does recovery vary by context, by culture, and in many ways we still haven't answered that. Like how is recovery different in the lesbian, gay, transgender community? And also a focus on what now is called the co-occurring community. So there still are a lot of unanswered questions about that, whether it's by race, ethnicity, or by community affiliation. In 2003, Lisa Najivitz came out with a book on women in recovery and started to look at women's particular needs. And she is highly associated with the intervention program called Seeking Safety, which is a series of modules for women with alcohol and drug problems as well as post-traumatic stress disorder. And there started being this realization within the treatment community that not just women, but many, most often women are also dealing with histories of abuse, sexual abuse, physical abuse, emotional abuse, and that there are certain kinds of recovery needs to identify those kinds of problems. We're just taking a little tour down memory lane. This is like year by year. Okay. In 2011, back to Alan Marlatt. He developed relapse prevention and mindfulness. And this book came out of his work where they introduced mindfulness therapy, again, something fairly new, an innovation adoption, to take Marlatt's work and to blend this together. And he also is very much a proponent of harm reduction therapy, so he would also be an innovator in the United States. Unfortunately, he passed away the same year that this book was published. So where are we now in the United States? Hopefully this might be of some interest to you. We have the Substance Abuse and Mental Health Services Administration, which is our overall federal government overview of treatment and guides treatment across the country. What's become very predominant now in the United States is a focus on recovery within the mental health community. The mental health community has adopted the peer-driven, support-driven aspects of addiction recovery. And they have combined this into, and also now we have more of a realization that many of our clients also have co-occurring disorders. And this would be a model. You can go online if you're interested in looking at this. And these would be many aspects of recovery that this model emphasized, that it's person-driven, meaning that it's individualized, there's respect and hope. There's many pathways to recovery. It's holistic. We look at the whole person. We use peer support, relationships. We take into account that person's culture. We take into account if the person has a history of trauma and how this impacts them, with a strong focus on people taking responsibility for their own recovery, as well as an aspect on their strengths. So it's exciting to see that our government is moving in this, and people that work predominantly in mental health as well, treatment, really are using many aspects of the recovery model, which is really changing the face of mental health treatment within the United States. In 2004, we now have something called Recovery Campus, and those of us that work in the college settings are excited to see how the recovery movement is coming to the college campus. And one of the emphasis on it is that for college students who went into treatment, want to stay away from alcohol and drugs, might be 15, 16 years old when this happens, they're 18 years old and they go to the college setting. And many of our students live on campus. There's still a strong culture of drinking, even though we target that behavior. But it's very difficult to fit in when all your peers around you are doing a lot of heavy drinking. There still is that kind of association about this is what college students do. So this is a magazine that's come out about recovery, and it's going like lightning across the United States to provide services to students around peer-led groups, around alternative activities, substance-free accommodations that are specific to that, as well as looking at reducing the stigma. Because we still have a culture where drugs are treated differently than alcohol. And a student might say, I'm in recovery, I don't want to drink. And other students may not understand that. Sure, you can have some drinks, what's the big deal? And really push and emphasize that. Just at the very, very tip of the early adopters now, there's some looking at heroin use on college campuses. It's a very small number, but if you're one of those people in that number, that's pretty big to you. It could be 20, 50 students. Right? It's very much a phenomena that's on the rise among middle-class young men, particularly in the United States. So that leads us up to RecoverMe. So where does the manual developed by Gary and Barry fit into this history of what we've learned about recovery? And I think the Minister White did a wonderful job of really summarizing what your curriculum is about. One of the things that really struck me originally about this work is that it comes out of the context of their work with women who have mainly heroin addiction. And I had mentioned this to Gary at one point. I've talked about this with my students. Typically, most products of anything that we see is based on developed with men. Pharmaceuticals gets tested with men. At some point, it's tested on women. What they have done is taken that model and turned it around. And they have developed this model based on their knowledge, their work, their experiences, of their clients' experiences, who are females, and with a heavy emphasis on feelings and emotions and relationships, because that's how women interact, is through relationships. But men do as well. And so they've been able to take a model developed through and by and for women and offer it to men. Totally different than typically what we would see. And it's been well received from what I understand, and the male clients respond to it quite well. The focus is on emotional and relationship healing. There are elements of the cognitive behavioral work about the messages that are told to oneself about one's use, as well as some coping skills and methods. And so this afternoon, my understanding is we're going to be sampling some of these curriculum modules, and I ask you all to participate and to give some support to our students who are going to be co-facilitators. And again, I want to thank you for inviting me. And this is my contact information if you wish to get in touch with me, but this has been a wonderful experience. I hope you've enjoyed our little trip down memory lane, and be happy to talk to you after our presentations are through. Thank you very much.
Thanks very much, Melinda. That was really illuminating, I think, and it put things into context. We tend to forget that there are very slow progressions in terms of the interventions that many of us would use now in relation to addiction, that it takes a long time for certain ideas to take hold. It's nice to be innovators and early adopters. I must say I loved that graph. Let's rejoice in those titles. And just to reiterate what Melinda said, there will be workshops dealing with RecoverMe after the main part of the conference is over, during and after lunchtime. You can gather up your sandwiches outside in the hall and bring them with you upstairs, and our staff will be there to show you where to go. So please feel absolutely free to participate. Our next speaker is Dr. Hilda Loughran, who is a lecturer in social work in UCD. And she has a particular interest in social work education, research, and drugs and alcohol policy. She's recently been researching in the areas of alcohol use, crisis pregnancy, community drugs work issues, and brief intervention. And she's been working with us in SAIL and exploring ways for participants to be involved in social work training, which is a highly innovative idea. Hilda, delighted to welcome you here.
I'm not going to say much about myself. I think that explains most of my activities, but I do come from a social work background, and I have been involved in, I was just actually totting up in my head, I'm almost 30 years involved in the area of drug and alcohol treatment. So I think that what's happening in SAIL is wonderful and innovative, and so I'm delighted to have been able to be associated with you in several other projects as well. At this particular project, I'm a little bit of, I suppose, I feel that I'm kind of like the party pooper, I think that's what they call it in a sense, because what I'm going to be talking about is a little bit to do with research and evaluation. And so for that, I haven't actually been involved at all in the RecoverMe manual, because my role is hopefully going to be trying to evaluate it, and for that you need to be somewhat more objective about what's happening. So I think in the field of addiction, one of the difficulties has been that for many, many years we had a view that nothing worked. And a lot of people who are not directly involved with people in the addiction field had that view. I certainly remember when I began to take an interest in working in the area of addiction, my colleagues in social work would have said, you're absolutely crazy, because, you know, what's the point in being involved in that field? Nothing seems to work. So at one end we have that view that nothing works. At the other end, we also have a view, I suppose, that we have a sense that what we're doing really does work. And we have an incredible belief in what we're doing and that it does work. And so what I'm going to talk a little bit about is the need to not be sort of concerned that nothing works, but equally to be able to stand over the fact that if we're saying what we do works, we need to be able to show that in some more objective way. So that's going to be my role from now on in trying to evaluate the RecoverMe. So just to, I suppose, to emphasise that there are a lot of challenges in terms of doing evaluation for the RecoverMe project. And these challenges are not new to the addiction field. In many areas of trying to do research and evaluative work in addiction, there have been serious problems. I mean, one of the classic huge projects that was conducted in the United States cost many millions to do, and it was a nationwide project, and it was called Project Match. And in that project, what they did was they evaluated manuals, not unlike the RecoverMe manual, where they designed a way of intervening using motivational interviewing, and they compared that to cognitive behavioural therapy and to the 12-step programme. And after spending a lot of time designing these manuals and doing very complex research on it, at the end of the day they decided that all three of them worked pretty much the same. And there has been an element of that in terms of our concerns about research in the addiction field, that it's been very difficult to really identify the key things that are making a difference. And I think Professor Hohman really alluded to that, and that is because maybe we've got a little bit caught up in the mechanisms of research. And one of the people in the addiction field that I have a lot of time for is a man called Jim Orford. And he very wisely said very recently, I think we've been asking the wrong questions. So I suppose in terms of the challenges for RecoverMe, we need to be asking a lot of different questions. What the programme is trying to do is to provide programmes for both people who are drug-free and people who are trying to reduce their use. So that in itself is quite complicated, because I think Professor Hohman mentioned that one of the things that has been typically used as a research evaluation outcome measure has been how long somebody has been sober or clean. And so when we begin to muddy the waters a little bit by saying, well, actually, you know what, somebody could be recovering and making good progress and not necessarily be fully free of drugs. So that is a huge challenge in terms of how we evaluate and measure that. One of the other things about this particular manual is that it's also attempting to do another very challenging thing, which is to work both with drug use and the area of intimate partner violence or domestic violence. And again, although people here probably think that's a very sensible thing to do, it has been something that any kind of dual diagnosis issues in addictions have caused real problems, because what we have is a service base that's set up to deal with one or the other. And so you're either in one service or another. The same with mental health issues. You know, are you in a mental health service or are you in an addiction service? And certainly, I think it must be probably 15 years ago since I was first asked to help work with integrating drug and alcohol services, and it really still hasn't happened. So in terms of being late adopters, I think we might be laggards, as Professor Hohman would say, in some of those areas. And certainly when it comes to dual diagnosis, which is what we think about when we say that somebody has both an issue around drugs and an issue about domestic violence, we really do need to be looking at how we can manage both of those two things, rather than saying, well, you have to deal with one first and then you can deal with the other. And I think this is what the manual RecoverMe is really trying to do. But I just want to emphasise that there's a huge challenge in doing that, and from the evaluation perspective, somehow or another we have to try and capture that challenge and then identify which pieces of it have worked and which pieces of it need to be changed. So in doing that, we're talking about valuing both the content and the process. So what that really means as an evaluator is that it's not just about a final outcome measure. Oh, well, did people stay in domestic violence situations, or did they leave them? Did they stay sober or not? It's much more complex than that, because we're talking about much more qualitative measures in terms of quality of life, changes that people have made. And in particular in this programme, where we're looking at people becoming much more confident and much more able to express themselves emotionally. And we have to find a way of measuring that. And there aren't easy ways to measure that. So that's going to be one of the challenges for me in trying to evaluate the programme. Providing a programme at the right time, at what stage do you provide this programme for somebody? And I certainly know that that's an issue that people in SAIL have been thinking about. When is the right time to do it? where in recovery does somebody have to be to actually begin to try and deal with emotional issues? If you try and do it too soon, is that likely to create a trigger for other problems? So we'll be looking at that as well. And I suppose one of the things that I really like about the project has been that there's already been an element of building on feedback, and I'm going to talk a little bit more about that in a few minutes. So what we're going to be looking at is trying to evidence what works. So rather than, I know that many people have mentioned that the work of SAIL has actually been very well received, and we know from feedback that a lot of people are finding the manual, the Reduce the Use manual, very helpful. And it's going to be my goal to try and figure out not just is it helpful, but why is it helpful, and can we actually stand over that with the credibility that we can then, be more transferable about what it is that works in the manual. So just to say a little bit, one of the things about, well, if this thing is going to work, sorry, there we go. There's been a huge debate in terms of all things to do with counselling and addiction field in particular, but even in the area of social work, this notion that we need to be having an evidence-based practice. And that seems like a very sensible thing, that obviously we want to do what we know works. But I'm going to just say a little bit about some of my concerns about that. I think we need to be having an evidence-based practice. So for that, I'm going to suggest that, what we need to do is we need to be practicing what we know works, obviously. We need to learn from research. So we need to be looking at other people's research, finding out what's worked for them, and trying to replicate that. We need to have research protocols. So in other words, we need to actually have embedded in the work that we do ways of tracking changes, ways of tracking, people talk about having a pre and a post type approach. So we know what was the problem beforehand, we know what the intervention was, and then we try and track how the intervention helped. So we need to work a lot more on that in terms of the work we're doing in addiction. In order to do that, we need to know how to do research, and we need to be able to be rigorous and to prove the validity of what we've done. And I suppose in a way that's partly from my perspective with this programme, is that I haven't been involved in the development of it, because I need to be able to stand back from that and be objective. And that's the plan of action for me anyway, to do that. But I suppose, there we go. What this evidence-based practice approach means is that and this is the bit I have a problem with, is that there's an element in which we value what's measurable. So we sort of prioritise what we can measure. And certainly I know from my years in working with clients that sometimes you have a sense of what's working, and you may not be able to measure it, but you sort of know that it's been helpful. So I would suggest that in looking at an evaluation of the programme, it's not just about an evidence-based practice. So in other words, it's not the evidence is leading the practice. We also need to have research being informed by the practice. So in other words, that the practice informs the evidence. And that might seem like a very practical thing to do, but in actual fact, in the research world, oftentimes we miss out on that. We don't really listen to people in practice, and we sort of say, oh, well, for example, motivation interview and cognitive behavioural therapy are the ones that have a big evidence base. When I investigated that, I discovered, well, partly the reason for the evidence base, not that I'm challenging that they don't work, but one of the things is that they've been researched a lot. And if you go back to that project match that I mentioned, one of the things that was really interesting about that was they researched a 12-step model, which had never really been researched before. So people used to often say, oh, well, 12-step doesn't work, and we've no evidence base to it. And we didn't have an evidence base to it. But lo and behold, when they finally did research it, it did just as well as the others. So I think we need to be just cautious about that. So what I'm saying is that practice-informed evidence is really and I don't know where I'm pointing this thing. Okay, sorry. So what that means is exactly what SAIL have been doing, which is to acknowledge the practice experience of people working in the field, and to actually listen and learn from the people who are availing of the service, and that's hugely important. And you mentioned that one of the projects that I've been involved with SAIL has been really trying to work with the service users in SAIL to help find out what it is they need social workers to know in order to work well with them. So listening to what clients' experience is hugely important. So what we're talking about then is researching that practice and actually giving a credibility to that practice led by the fact that we feel it works, we have a sense that it's important to clients, but we have then to go after the evidence. And that's really what this model we're going to use in terms of RecoverMe is going to be about. So that's about enhancing understanding. It's not just about having very simplistic, maybe perhaps overly simplistic measures, like saying, oh, well, how long did you stay clean for, when did you relapse, those kind of very concrete and specific measures, but that doesn't really explain issues like Professor Hohman said about quality of life. So my pitch would be that we also have to measure what's valuable. And I think that's really, really important. So it's not just about valuing only what's measurable, but we have to really try and attempt to measure what's valuable. And that's really what I'm going to be doing, hopefully, with the project from now on. I'm going to just say that that's not to underestimate the fact that, in general, when we think about evaluative research, we think about two types of evaluative research. One is formative, and the other is summative. And in terms of formative research, this particular manual has already gone through the first iteration of that process, because people developing the manual have been very meticulous in getting feedback from people who have been using it, in building on, what is it that seems to be working about this module, refining it, and really listening to the people who have been using the manual. And I suppose the next step is to try and be more objective and say, well, what is it that's actually working about the manual, and then obviously to go back and to redesign it. And somebody mentioned the fact that this is the final product. I'd hasten to say that it probably isn't the final product. It's the current product, but my guess would be that hopefully when everybody who has started to use the manual gets together and figures out, what's been working about it, what's helpful about it, what's not so helpful about it, there'll probably be another edition of it, as I think happened with the reduce the use as well. So I'm very confident that if I come up with interesting ideas, or if people that we've been involved with come up with interesting ideas, it will be incorporated. So just, I was probably going to do this, and I'll just fly through this piece, so I'll put it all up there rather than in little bits and pieces. So partly what we're going to be looking at is ways in which we can do something that would be perhaps like looking at the kinds of issues that have been there for clients before they begin to use the manual, trying to identify things like, for example, what criteria have been used to include somebody in doing the programme, the timing of the intervention, trying to figure out, exactly the variability in terms of their drug use status, domestic violence status. And ideally, I'd really like to try and see if we can do some way of trying to measure that before the programme, what kind of emotional knowledge base did they have, what sort of fluency about emotional language, since that's a key part of the programme. And then to actually look at how the programme has improved that for people. Partly this will also be involved access to service, what kind of, there's a big difference, I suppose, in working with somebody who's had a lot of service support and then somebody who has had very little service support. So that part will have to be taken into account as well. And then the final piece is about programme delivery. One of the key pieces that we're concerned about in terms of research is have we stuck to the programme? Have we been faithful to what the programme is attempting to do? And I suppose that's one of the reasons why the training into how to use the manual is so important, because the closer we can the more clear that people can be about how they're using the manual and the purpose of the manual, the better chance we're going to have of being able to evaluate what they've done and to be able to stand over that evaluation. So that's going to be something that we need to look into. And then the idea would be that to review then people who've been involved in the programme and trying to find out, obviously, to continue with the process of getting their feedback, continue with the process of getting the provider's feedback on the programme, then beginning to try and look, as I said, for some objective outcome measures, although I'm not madly obsessed about those, but I do think it would really help to legitimise and give further credibility to what's already a very useful programme if we can do those kinds of things. And obviously then really trying to figure out, can we attribute success to elements of the programme, or is it just that life happened for people and, as people move on, life becomes perhaps more manageable for them anyway. So we're going to try and look at those issues. And then, as I said before, already the manual has some built-in research, and we'll be developing on that. So hopefully we'll be saying watch this space, and that we will be able to identify some very strong measures as to how this programme is working and what's useful about it.
Thanks very much, Hilda. That's a scary prospect, this evaluation coming up with all of those fantastic items listed out for us there, but I'm very confident that Gary and Barry will be well up to it, and we're delighted to have someone of Hilda's status evaluating this programme for us, because it's very much part of SAIL's ambition that we evaluate our programmes regularly. Our next speaker is Dr. Paul Dalton. He's clinical lead in the Department of Psycho-Oncology in St. Vincent's Hospital. I didn't know there was a Department of Psycho-Oncology in St. Vincent's Hospital, but it's very good that there is. And he's also an adjunct lecturer in psychology in UCD. And he's particularly interested in the application of mindfulness-based intervention in healthcare, which he's going to talk to us about today. And of course, mindfulness is part of the philosophy that underlies RecoverMe. Barry, who you'll be hearing from later, is very interested in that whole area. Paul, you're very welcome here today.
Thank you very much. Good morning, everyone. Very nice to be here. The last time I spoke in here was about a year ago at a palliative care conference. And so I was a little bit anxious today because I don't know if I did very well the last time. There were a couple of people who kind of fell asleep in the front row. And they were, very kind palliative care nurses and doctors. So bear with me. I sent Gary on the slides yesterday, and there was kind of 50 of them, and I could hear his heart sink when I sent them. But I'll do my very best not to bore you. I work in St. Vincent's mainly in cancer care, and have done for the last 8, almost 9 years, and I work a bit in the School of Psychology in UCD. Over the last 10 years in St. Vincent's, we've had almost 400 cancer patients through the 8-week mindfulness programme. And we just recently finished a very large trial, a randomised control trial with 102 patients in that. So we've been doing kind of mindfulness interventions there for a while, and that's some of what I'm going to talk about today, is bits and pieces that we've picked up over the years in working in mindfulness with patients who are in distress. Very often the patients that we work with are patients with a terminal diagnosis. I am co-director of the new program in the School of Psychology in UCD, a master's program in mindfulness. We've just launched an MSc in mindfulness-based interventions, and I'm really pleased to say that Barry is going to be in our first cohort of students starting in September. So we really actually consider ourselves really lucky to have him there, given the work that he's already done and what he's going to bring to the programme. So we're very pleased. There are essentially, before I send anyone asleep, there are three kind of main points that I wanted to talk about today. I wanted to talk a little bit about our brains, so what goes on inside our heads and our hearts. I wanted to say that in the last 10 to 15 years, the research is telling us quite a bit about what's happening in our heads, in our brains, through advances in imaging. And the bottom line is, the take-home message is that we have brains that we inherited, and they're tricky. They don't work very well, okay? They're tricky. And when we add in empathy, so we're all talked to about the importance of developing empathy. When we add empathy into these tricky brains, they get even trickier. So I'm going to talk a little bit about that today in some caution. The other thing I'm going to caution about is mindfulness. I direct the program in UCD and have been teaching it for a long time, but we've got to be very careful about about understanding or seeing mindfulness as a cure for all ills and all remedies. It's not. And I want to be really clear about that. We, at some level, the science of mindfulness, the evidence base, the knowing what works, knowing what questions to ask about mindfulness, is all catching up with the practice. Everyone knows something about mindfulness now, but in fact, the evidence base is only building. So we've got to walk this with caution. The third thing that I'm going to talk a little bit about is the idea that what we emotionally, what we resist, what we push away, persists. Okay, so what we resist persists. And the idea that the probably one of the most helpful ways for us to manage our psychological or our emotional distress is to, ironically, or contradictory to what we might have been told, is to experience it fully. So when we continue to shy away from or avoid our emotional experience or our psychological experience in pain, it gets worse. So I'm going to talk to you a little bit about that. But before we do anything, if you could just put down what you have in your lap. So if you've got some note paper or some pens, just put it on the floor. And this is a pause break, a kind of a 3-minute mindfulness break. So we've been working very hard. So finding your feet, allowing both your feet to be flat on the floor. And if it's comfortable for you to close over your eyes, but you don't need to do that. If it's not comfortable, just to allow your eyes to rest gently just in front of you. And then to put your hand on your belly, so your right hand on your belly, and just to notice your breathing. Quite simply noticing your breath, nothing else. Not changing your breath because it doesn't need to change. How you're breathing is more than okay. So just noticing the sensation of your own breathing. And then paying attention to your body. Noticing your feet on the floor. And then noticing how close your shoulders are to your ears. And allowing your shoulders to soften even a little bit. So it's often we carry our tension and stress and worry in the shoulders. So allowing the shoulders to soften. And then bringing attention and noticing what's going on in your heart or your emotions. So if you can, just kind of say how you're feeling to yourself. Happy, sad, bored, restless, joyful, whatever. Just you can kind of name the emotion. And then bring your attention back to the breath. Feeling the belly expanding and contracting. Knowing that how you're breathing is more than okay. It doesn't need to change. Just bringing your attention to the breath. And when you're ready to open over the eyes. So, a mindful moment. The Jon Kabat-Zinn, people may have heard of, introduced mindfulness in a healthcare setting in the 1970s. But John has said recently that, in fact, he probably gave it the wrong name, that it should have been bodyfulness, that we need to kind of move away from our minds, actually, and back to our bodies. We have our minds, we have our brains that have developed over millions of years. And much of what goes on inside the hard drive in our heads is not our design. It's not our fault. And in fact, it's probably designed fairly poorly. I don't know who said it, but we are designed for survival and not for happiness. We was reading a very interesting book recently, and called Ending the Pursuit of Happiness, because it's our pursuit of happiness actually that makes us unhappy. We are designed to survive and not to be happy, despite what we may have been told over the years. The important thing is we have a hard drive up here that we didn't create, we've inherited. And it's our tricky brain. And this brain, as I said, gets a little bit more tricky when we add in empathy. we've an old brain down here in the middle of the head. If you put your fist together, kind of like in here. And in here is where our emotions, our desires, our motivations, our basic motivations, and our relationship seeking happens. So those more basic or more primitive aspects of who we are as individuals operate from. And then we have this thing that I very simplistically call a new brain. And the new brain is kind of largely at the front of our heads, these lobes here at the front. And they're essentially where we do our thinking, our planning, where we do our worrying, our ruminating. It's where we imagine wonderful things and awful things. It's where our self-awareness is and our identity is. So all of those aspects of ourselves happen in this part of the brain, in the new part of the brain. It can get tricky because in this very simplistic version, because this is how I can kind of think about it, this can get tricky because the old and new brain don't always communicate in a very good way. We find ourselves here, like the man at the top of the evolutionary progress there, where we have moved from a species where our concern was about eating, our survival, and our ability to reproduce, to a capacity as human beings where we actually begin to ask ourselves questions about what is it all about? Who am I? What's it worth? We begin to ask these questions, and these questions are difficult and challenging. We, unlike the chimpanzee or the monkey, you know that if you've had a dog, for example, in your life, really the dog is not concerned about what's going to happen tomorrow or what happened yesterday. It's present focused, and we are, of course, because we've got to plan, and there's nothing wrong with that. But it causes us problems because we begin to think into the future and we begin to plan. And if you're anything like me, you probably insert the worst possible scenario. Yeah? So there's a gap and we insert, or we remember what went wrong the last time. So like the last time I was here, I remember that, right? And then that affects how I am right now. Our capacity to worry about how we are going to appear in the world. This is unique to us, and it's unique to our new brain. It's unique to this part of our brain. This is unique to us. So our concern about how do I appear, how do I look, am I going to be valued and respected and loved? And again, that idea that the new brain asks us to question and to judge and to criticize our natural responses and experiences. And interestingly, when it comes to empathy, and those of us in the helping profession know that animals don't do courses in empathy building or becoming a more empathic person. Us in the caring profession, there's a great emphasis on developing our skills in empathy. And that's quite a burden to this brain. In the literature, there are two kind of areas of empathy, a kind of affective empathy, or empathy that's related to our feelings, and cognitive empathy, empathy that's related to kind of how I think, or how I think you might be thinking, so our ability to take someone's perspective. Again, from the literature, there are probably three key dimensions to empathy that are worth talking about today. So empathy really does involve our ability to take perspective, right? To think about how the other person may be experiencing an interpersonal situation. This idea of theory of mind, that, and those of you who have children will know that a child will begin about 3 or 4 years of age to realize actually that the other child has something going on that's not going on in my mind. And that's called a theory of mind. We suddenly go, oh, actually, your mind is different to mine. hopefully. The empathic concern, that we have concern for people's feelings and a concern for others. So just that genuine concern. And then personal distress, because when we when we have empathy, we experience discomfort at the emotional experience of other people. So we see someone in distress and we become distressed for them. Our old brains, as I said, these brains that we have are tricky. And then we add in empathy and they get even trickier. These new brains that we have, so this new part of the hard drive, hardware that we have in our heads, are generally shaped by our early environment, by the early attachment experience that we have. So when it comes to imagination and relationship formation, when it comes to thinking about possibility and problem solving, when it comes to a sense of safety in the world, those areas of the brain, those areas of mind and heart, are generally formed from our early experience. And many of us, if we had the choice, may have changed our earlier experience. We may have opted for a different script in our lives. The brain that we have come to know a little bit more about over the last 2 decades, and researchers in the field refer to the brain as having a default network or default mode. So this is the experience that we've all had, that the brain has an incredible capacity to wander, a tendency to wander. So you know the idea when you are sitting in traffic or you're lying in bed at night trying to go to sleep, the mind wanders from A to B to C and back. So it's almost like a kind of a roundabout. And this happens when we're not paying attention. So when we decide to pay attention, as you did to your breath, for example, the mind can focus on that. Otherwise, that's the mind's default network, is to go to all of these different possibilities. And generally they are possibilities. And generally they're worst case scenario. This is a function of the brain that has evolved over years in order to keep us on our toes. And this basically is about better safe than sorry. So if we think about the worst possible scenario, right, we're actually, as difficult as that is, we're better off thinking about that because it's going to keep us safe. The problem is when we begin to think like this over a long period of time, that various areas of the brain are stimulated so that there's a path worn for us to think, for us to worry, for us to be concerned, for us to be disconnected from ourselves. So we actually wear a pathway in the brain that keeps our minds on the move. You know that kind of, you know the tired but wired phenomenon? You know that one where you're actually physically exhausted but mentally wired. Because we've done a lot of training in our brains in order to keep ourselves that way. So it could be the anxiety, girl or boy, but that ability to jump to the worst conclusion in a single bound. And that is part of the better safe than sorry. So I might think today coming in here, yeah, I'm really, really not going to do very well and they're all going to get very bored, right? And that in some way keeps me on high alert, right? So not necessarily a bad thing. The problem is when we get stuck in that. Anyone recognize this? The thing is our brains leave us very, very vulnerable to overload, to thinking of potential possibility and outcome. So you might recognize that experience yourself. How we respond and react to and appraise our problems is key. This is why the importance of psychological or emotional counselling interventions, that this is not something that's set in stone, that there are ways, and we learned from cognitive therapy over the years, to reappraise and evaluate our problems. And key to our experience of distress is our ability to appraise and to evaluate. But key in that is awareness. So we can only reevaluate how we're thinking if we know what we're thinking. Otherwise, we get stuck in the fight or flight. You know that fight, flight or freeze, where we are wound up, ready to pounce, ready to run away all the time. That system, biologically and psychologically, is really important for us. It ensures our survival. So it's like you're standing ready to cross the road and a kid walks out in front of a bus. What do? You don't think about that. You respond immediately. That's really important. We never want to lose that. The problem is when we get stuck in fight or flight all the time, when we get stuck in high alert. Does that make a bit of sense? That's not how we need to live. The problem is we have a tendency, as you know, in our minds to live in the past or the future. And we have a big problem living in the present moment. And depending on probably some of the early experience in our lives, we will have a tendency to focus on the past and probably be depressed, or focus on the future and probably be a little bit more anxious. We get stuck in what's been referred to as reactivity, where we are reacting in our lives. We are on automatic pilot. And this automatic pilot prevents us from seeing clearly, from solving problems and expressing our emotions constructively. So when we're on high alert, when we're in fight or flight, like the cat, we don't solve problems and we don't communicate emotionally very well. And I mean, all you need to do is to think about that is at a time of stress or difficulty, our worlds just become narrower and narrower and narrower and narrower. And we don't solve problems and we don't communicate properly. The problem about this is that a lot of it can be unconscious. It results in us being on high alert. And this model is based on work probably over the last kind of 40 years or so that looked at stress and our ability to cope. More recently, Jon Kabat-Zinn in the 90s emphasised that our awareness of our options and our ability to come out of automatic pilot. So we can live our lives unconsciously in the past or the future, or we can develop an awareness for the present moment. So noticing this breath in this moment, these feet on the floor. Noticing how close your shoulders have gone back to your ears is a really good way just to come back to this moment, to take ourselves out of automatic pilot. Mindfulness began in the late 70s in the University of Massachusetts with Jon Kabat-Zinn, and there are over close to 20,000 individuals have gone through the program in the University of Massachusetts since it was established almost 30 years ago. And this essentially was the application of some contemplative or meditative practices in a healthcare setting. And Jon Kabat-Zinn began this work with people with chronic pain. And doctors were going and saying, there's nothing we can do, it's hopeless. And he thought, well, actually, why don't we teach them how to meditate? And that's what happened. So mindfulness is a way of developing our ability to pay attention in the present moment, non-judgmentally, to be curious about our experience. And that takes work. Someone described it recently as it's like brushing your teeth or minding your teeth. It will not happen. It's no use going to the dentist or the person who cleans you, the hygienist, once a year. You've got to do this every day. So learning to be mindful, learning to be in the present moment, to come out of automatic pilot is something that involves a commitment and a practice on a daily basis. Very quickly, what mindfulness is not. Mindfulness is absolutely not about trying to relax. Mindfulness is not a religion, whilst it's based on some largely Buddhist or contemplative traditions. It isn't. It's a secular application. Mindfulness is not about transcending ordinary life. Sometimes people have the idea that if we become mindful, well, then we don't become distressed or pissed off or frustrated or annoyed. That's not true at all. The idea is that we go more fully into our experience. And it is certainly not about emptying the mind of thoughts. We always say to patients when we teach the program in the hospital that as long as you're breathing, your mind is going to wander. So the mind will wander. It's what they do. It's what they're evolved to do. They have evolved to look out for danger, to be on alert, better safe than sorry. And mindfulness is not difficult. I'm not sure about that, actually. I think it is. And mindfulness is not an escape from pain, but actually it's a way of entering into our pain more fully in order to ease. There are two basic interventions in mindfulness, mindfulness-based stress reduction and mindfulness-based cognitive therapy, both developed over the last 30 years. Again, I go through this very quickly. Mindfulness-based stress reduction, established in the States in the late 70s. And more recently, mindfulness-based cognitive therapy out of the Oxford about 15 years ago, and both manualised programs. Mindfulness-based cognitive therapy is now recognised and recommended by the UK's National Institute of Clinical Excellence as an intervention for people, and recognised to be as effective as antidepressant medication for people with recurrent depression. Mindfulness is gaining ground in the research literature. I think this is up to 2011. I couldn't find anything more recent. So that's the number of publications that have happened about mindfulness since 1980, where there were 0. So this is gaining a strong foothold in clinical application and in research. So asking the questions about what is working here, what is not working here. These are the peer-reviewed, publications up until 2013. We can see there are 240 in mindfulness alone, and grants awarded in the area by the NIH up to 2013. So this is a big area, and this is the piece that the work that Barry and Gary are going to contribute, both in terms of hopefully grant funding and in publication. The research tells us that mindfulness is good for various things: heart disease, improving our immunity, fertility, focus, anxiety, blood pressure. But John Kabat-Zinn, again, the man who introduced a lot of this, to emphasise that during mindfulness we develop an awareness of our options and the ability to come out of automatic pilot. He also describes, which I really like, the idea of coming to terms with things as they are. So he says that actually healing from an emotional and or physical point of view is about coming to terms with things as they are, rather than changing them. The skill that, psychologically speaking, so people do some mindfulness training, and the skill that they learn is what's referred to as metacognition. And metacognition simply means the ability to think about our thinking. The ability to think about our thinking. So here I am having thoughts, I'm having feelings too, and developing an ability to think about them as the first option, first stage. Got to know what's going on in my own head. Important to say that the attention training, so learning to think about our thinking, we need to be careful about that. And I always remember the piece from Eliot, who says that humankind cannot bear too much reality. So we've got to be careful about what we expose ourselves to. And as I said at the beginning, the science and the evidence base is catching up with the practice and popularity of mindfulness. So we've noted caution around it. Through some of the research, and the people who are writing and thinking about mindfulness more recently, the area that's gaining prominence is compassion. So there were a couple of studies done. That said basically what seems to be bringing about the change for people who undergo mindfulness training is this idea of compassion. And I'm going to go on and talk a little bit about compassion now. The compassion has been described is understood as the ability to suffer with. So coming from the Latin compi empati, to suffer with. And it is a deep awareness of our suffering coupled with the desire to relieve it. And compassion has two main pieces. It's the ability to open up and tolerate and understand our suffering, and the psychology of knowing how to alleviate suffering and uproot its causes. So we tolerate it, and then we look at a way of alleviating it. Again, compassion has been referred to as the acknowledgement that not all pain can be fixed or solved, that there are emotional, psychological and physical pain that cannot be fixed, but that the suffering we experience is made more approachable in a landscape of compassion. The Tibetan word for compassion involves compassion for oneself, and the Dalai Lama has said that if your compassion does not include yourself, it's not complete. And in fact, it's only in the English language that we use the compound word self-compassion. In other languages, compassion naturally involves oneself. There isn't a distinction between me and me being compassionate for someone else and being compassionate for myself. But in our language, we've introduced the concept of self-compassion. Self-compassion, having a common humanity where we see ourselves as part of the bigger picture, having self-kindness, and being mindful. And self-compassion is, the more recent literature is telling us, it's linked to our biological experience. We did a very small study in the hospital 2 years ago. So the intervention group are the intervention in green, so you can see their depression reduced significantly and their self-compassion increased. And their telomerase activity and enzyme in the chromosome actually changed as a result. So we saw biological changes taking place over an 8-week period. These were a group of patients. One of the concepts in mindfulness is this idea of the second and third arrow, that we have an experience in our lives that we don't like. That's inevitable. We grow old, we get sick, people we love die, things go wrong. There's no changing that. What we do have the option of changing is the second or the third arrow. And the second and the third arrow are the resistance that we put in place when the inevitable happens in our lives, when things go wrong. So the criticism that we can often levy on that, the refusal to accept what's actually happening. The Dalai Lama says that it's not our experiences that cause us suffering, but it's our resistance to them when we push them away. Self-compassion correlates, the literature tells us, with a whole host of positive life measures. We find ourselves as human beings here with this apparatus in our heads that we're not responsible for, old brain, new brain. We find ourselves here having evolved. We didn't choose to be born. We didn't choose our genes. We didn't choose our emotional state. Most of us didn't choose our name. We didn't choose our basic temperament. We were born this way. We didn't choose our body and how it works. We didn't choose our basic human desires and needs. These are all pre-programmed. And we didn't choose the time in history we were born. We made none of those choices. So much of where we find ourselves today is simply not our fault. We've inherited so much that we're not responsible for. But we add a second and third arrow to ourselves by blaming ourselves. Self-compassion is very different to self-indulgence. So when we talk about self-compassion, patients always say, well, if I become more self-compassionate, I'm going to let myself off the hook altogether. I'll go wild. I'll reuse. I'll relapse. I'll do all of those things. But we know from the literature, we know from experience, that self-compassion is very, very different to self-indulgence. Self-compassion at times involves saying no. Self-compassion involves making very difficult decisions in my life. We, to summarise, and I'm going to finish now, really important from what we know in the mindfulness literature, what we know in terms of our self-care, is that we do not believe everything we think. And actually, when we find ourselves really, really, really knowing that we're right and really believing something, then's the time to really challenge it and question it, because then's the time you're probably wrong. So thank you very much, and I hope that made a bit of sense.
As I'm sure you can see, Paul, you were very far from boring anybody with that. That was a rock star turn. I always remember the Sopranos TV series. Tony Soprano had a relationship with a woman who was a Buddhist, and he asked her, what do you want? Which was his favourite question. And she said, joyful participation in the suffering world, which is a pretty good mantra to have if you're dealing with Tony Soprano, I would imagine. Didn't work out in the end, but there you go. He wasn't able to rise to her level. Our next speaker is Barry Costello, and in many ways this is Barry's day. This is the man who has Barry has been with SAIL since his placement from college in 2010. He's an extremely valued member of our extremely valuable staff, and he is the person who is mostly to thank for putting together RecoverMe. And we all know, who are connected with the project, the very long hours, the weekends coming in, the endless proofreading, all the stuff that had to be done. I'm sure it nearly drove him out of his tree, but he, I know, is really, really proud of it, and we are really proud of him for having put all of this energy into it. He's going to talk to us now about RecoverMe. Barry.
Thank you, Katrina. I didn't hear a word of it. I'm only joking. I'm feeling slightly nervous. This is the biggest crowd I've ever spoken to. Just I suppose RecoverMe would tell me to be aware of where I feel it, and mindfulness is telling me to breathe. So I'm trying to do both things at the same time at the moment. Just I can't believe that what started out as a conversation 2 years ago in Gary's office has got us to here. I want to thank everybody who helped along the way with the reading, rewriting, editing, making dinners, lunches, everything that happened. But I especially want to thank two people. One is Gary, who's the boss, for believing in an idea, but also for your support and encouragement along the way. And the second one will be to my wife, Jenny, for all your support, understanding and friendship, and for looking after the family when I moved into SAIL a month ago. Have the clicker. Addiction can be seen as a lifelong interaction with a person's social and emotional surroundings and within their own internal psychological space. When working with clients in group or one-to-one, we often discuss beliefs, mindsets and emotions that feed addiction. We have learned through our own training that these are the reasons why people often stay in the addictive cycle. When we speak of these topics, we often assume that the client understands the language and the process involved. We have found in SAIL that this is not always the case. From working with the women who completely reduced to use 2 and the changes that it brought, there seemed to be something needed. A number of questions were being raised. What was the next piece? I've reduced my use, but I do not know how I feel. I have all these emotions coming up and I'm not sure how to name them or why they are here. Although at a head level, recovery seems like a good choice, I'm not really feeling it. A lot of discussion around this time with people in recovery can centre around negative self-labels such as depression, anxiety, boredom, guilt and shame. RecoverMe helps to answer these questions and also hopefully gives people the language of recovery. RecoverMe and compassion, and it's good actually I put this slide in just following on from Paul. This is a definition by Dr. Paul Gilbert on compassion, but compassion can also be described in the words of Miller Williams. Have compassion for everyone you meet, even if they don't want it. What appears to be bad manners and ill temper, a cynicism, is always a sign of things no ears have heard, no eyes have seen. You do not know what wars are going on down there where the spirit meets the bone. The foundation of RecoverMe is compassion. Compassion for self is a major part in recovery. Often people in recovery can be quite harsh on themselves and on their journey. When we approach our difficulties with compassion, we take back control and we learn new ways to respond skillfully to our difficulties. By bringing compassionate awareness to the present moment experience, both internal and external, can promote a greater sense of choice and freedom. Acceptance of where I'm at helps relieve pressures on participants are or may be putting on themselves in terms of shoulds, coulds and musts. It gives participants the opportunity to learn and to be understood. Acceptance is not a passive stance, it is actually about empowerment, laying a solid foundation for change. The exercises are designed to raise awareness, encourage participants to look at what they feel comfortable with and also what they don't feel comfortable with, helping to nudge people out of their comfort zone. That said, RecoverMe, the programme, is person-centred and moves at the pace of our participants. RecoverMe and success. Success in recovery is often something that is taken for granted, people often minimising the effort that they've put in or dismiss the significant milestones along the continuum. Success in recovery can bring a new set of pressures and demands, while also arousing emotions that often feel conflicting and confusing. Success can also feel like it is something to be avoided as opposed to being embraced. What may seem like the natural progression to many can be one of the most difficult steps for people trying to achieve recovery. As Marianne Williamson says, it's our light, not our darkness, that frightens us most. RecoverMe recognises this and encourages participants to look at the successes that they've had in the past, acknowledging and embracing each one. It also looks at the possibility of further success and what they can put in place to help them embrace it rather than avoid it. RecoverMe in the middle way. A word often used in recovery is balance. Finding a sense of balance is important, but in recovery it often leads to a very thin line in which a person must walk, where plans can become very rigid and there are little or no room for manoeuvring. The journey becomes a very rigid set of have-tos, which lead to striving for perfection. Being human does not equate to being perfect. Emotions, thoughts and behaviours and life in general do not tend to flow in a straight line. People will meet many challenges along the way. Recovery needs a flexibility that will allow room for living. RecoverMe offers participants an opportunity to look at areas of their life that they can allow room for flexibility. If you allow room for life's ups and downs, you may discover a new path for recovery. The middle way does not encourage reckless behaviour, but encourages group members to allow flexibilities within their plans. And just recovery in terms of the context, or emotions in terms of the context of recovery, as Mindy spoke about earlier on, Dr. Alan Marlett. Dr. Alan Marlett was a research psychologist and a leading writer in the addiction field, states that the three top reasons for lapse or relapse are: 1 would be difficult or challenging emotional states. 2 is social pressure, including social pressures associated to substance misuse that does not involve direct peer pressure, that can be attending parties or functions. And 3 is interpersonal conflict, which often arises in the family or partner relationships. All 3 situations can be seen that emotions are the underlying cause of difficulty for the emotion. This can also be found in the work of Bone et al. In 2011 and other leading writers in the addiction field. I'm doing okay, am I? So what are emotions? Emotions do not happen in isolation. There are many different factors at play at one time, including body sensations, thoughts and urges. When emotions are aroused, we often respond to them. Our response to them is normally based on past experience without us even realising it. But it's not necessarily the past experience that causes the difficulty, but how the past experience influences us today. When addiction is or has been a part of someone's life, dealing with emotions can be difficult. The thoughts, the sensations, the urges that accompany emotions can often feel overwhelming. There can be a tendency to want to fix or avoid the difficult ones, or to cling or grasp on to the ones that we like. RecoverMe works with participants in the here and now in terms of emotions. It asks participants to bring full awareness to all the factors at play when emotion is aroused. It not only teaches new ways of describing emotions, but also offers new ways of understanding them. This understanding gives opportunity and choice to make responses rather than react. Throughout the RecoverMe program, participants are asked to bring this awareness to their own experience by filling in emotional diaries daily. Triggers, thoughts, and emotions can often feel like a very automatic process. By filling in the diary, it also helps to slow this process down. The diary also includes body awareness. When we feel an emotion, it'll register somewhere in the body. Learning to tune into the body is a great guide to discovering how we are doing emotionally. The body will let us know what is happening. If we feel stressed, the body may feel tense, the shoulders are tense, the chest is tense, the heart is beating faster. If I feel happy, the body feels lighter, there'll be a smile on my face, chest feels lighter and stomach feels full. By filling in this diary, participants will begin to see patterns of how their emotions connect to drug use or unhealthful behaviour and what triggered them. It also reminds people of how they coped, what they did, how they felt after their actions. We often spend most of our time of the day in thoughts and not fully connected to the full range of experience that accompany emotions. The Emotions Diary helps participants to become aware of what emotions they are experiencing, immediate thoughts after triggers, body sensations, behaviours, emotions following the behaviours, and also a reflection in the consequences of that behaviour. Bringing awareness to our moment-by-moment experience can offer a range of responses that may help participants to be less reactive and more thoughtful and in control. The programme is inspired by the women of Sale, who were here in front of me. We found that from working with the women who came into Sale that they needed a programme that would help them understand their emotions. The programme is a collaboration between the participants and the Sale project. We listened to what the participants were saying and what they needed. Each exercise that is in the programme is a reflection of what the women have told us about recovery. RecoverMe would never have happened without them. So when we sat down 2 years ago in the bedsit, because Gary's office was fondly known as at the time. We were left with two options. The first one was, do we give participants a sheet with different words on it and ask them to go off and learn it? Or the second one was, do we design a programme that would not only help them to improve emotional vocabulary, but also help them to understand their meaning? A programme that could help participants learn that a part of life and recovery is that we will feel emotions. We do not have to fix these, we can learn new ways of being with them. Thankfully, we decided on the second one. As I already said, the programme was done in collaboration with other agencies. RecoverMe has been running in Sale for 2 years. We knew it was making a difference in people's lives, and we felt that it could be shared with other people who were trying to achieve recovery and other agencies. RecoverMe was piloted in 4 other agencies, and the feedback was extremely positive, and we're very, very grateful for your assistance in the development of the programme. Some of the key feedback was, it is something that has been missing from the addiction recovery field. This programme is not about the to-do, rather it explores the how of recovery. Impermanence was an important learning. Becoming aware of the ongoing emotions of daily life helped people to be less swamped by their big problems. In one group that was only for men, it was recorded that it allowed them a chance for one of the first times to openly discuss feelings and how they impact on their lives. It also gave them an opportunity to bring this learning home. Women loved the process. This programme helped them to normalise what was going on. It helped them to be more connected, to discuss, and to return to a more natural relational state for women. It helped them to engage in problem solving instead of problem fixing. Just because I'm feeling a certain way doesn't mean it has to be fixed. Maybe the best solution at the moment is just to sit with it. Overall, participants found it refreshing, and it increased the emotional vocabulary, allowing for more confidence. Each module contains 8 different parts in it, so which means that if the programme has 12 modules, but not all, you possibly won't get through it in 12 weeks. What may happen is that some of the modules need to be divided. We put a structure on the modules or sessions to help everything stay the same. The first part is a grounding exercise, which is a short meditation. We then move to a brief check-in. We then review the emotions diaries and any other homework. Each session has specific content relating to the theme of the module. We then review the session and prepare for the next one. We then have another grounding exercise which leads us to our safety plan. And then there's also the feedback and evaluation forms, which would be very much appreciated if you are going to run it, that they are filled in. The programme has 12 modules. Each module is linked and builds on the previous module. Exercises are designed to build awareness and to help with understanding. On participating. RecoverMe does not expect people to be drug-free, but it does ask for a level of stability from participants so that they can engage in the programme. And RecoverMe does not ask connections from the past. That is the work that can be done with counselling and therapy groups, but how emotions and thoughts are influence us and a recovery in the here and now. RecoverMe can then be summarised, and these are in the words of Gary Broderick. A programme where new beliefs are presented, tried out, and then used to create new goals for continued recovery. This occurs in a reflective environment of participation, acceptance, compassion, and evocation, where the facilitator is actively engaged with the learning as the participants. Thank you very, very much.
We know who the star of the day is, and richly deserved. Thank you, Barry. That was really informative in terms of taking us through how the programme developed and what it consists of, and it's a great tribute to you that it has got to the extent that it has. We're moving on finally to SAIL's wonderful director, Gary Broderick. He's been with us one way or another since 1998. He could have a fantastic academic career because he knows all about addiction and addiction studies, but he has chosen to honour us by being our director. He had a hard act to follow in the great Joan Byrne, who's sitting down in the front row there, and we kind of had an ideal handover situation because they shared the directorship for a while before Joan moved on to where she is now. But Gary has been an absolute revelation. If I were to describe him in 3 words, I suppose they would be innovative, enthusiastic, and funny. He makes me laugh all the time. We're very lucky to have him, and he's going to wind up the morning's proceedings now. Gary.
I can't feel my tongue at the moment. Thought we weren't allowed to use the word grand. Eloise said to me this morning, "Are you not very hot in that suit?" Well, I am now. I just wanted to thank you all for being here. It's great to see so many people. Nerve-wracking, but very good to see so many people. It's been wonderful to feel the support as we've been preparing for today. But it's great that you're here celebrating with us, and I know many of you will use this, so it's even better to feel that the work we're doing is taken on. But I want to pay particular tribute to Barry and to recognise all of the work that he's done in this. And you might notice in the acknowledgements that he's thanked for all of his extra time. He put in a phenomenal amount of time into this. None of which he's getting back in time in lieu, by the way. But it really was, and as Minister White said earlier, it's on top of the daily work which continued. And it's a tribute to the way the staff team work with the people who come to SAIL. Jura O'Rourke has a saying, well, she has several sayings. But she talks, and Belinda knows all about this, about being as rare as hen's teeth and as handy as a small pot. And I think those two together describe the team in SAIL. They're as rare as hen's teeth and they're as handy as a small pot. Because they do all that's asked and more, and then they'll come with ideas of what needs to be done. And that's what Barry did in talking about RecoverMe and in making it happen and it happening so well. And it's all well and good having ideas, but if you're not any good at following through on them, then that doesn't really help. But we're just blessed that in the team that we have that there. So to Aisling, Ger, Sue, Barry, Jennifer, Teresa rather, just changed her name, Rose, Kirsty, Sandra, Joanne, Belinda, Josh, Michelle, Bernie, Rachel, Monica, Mary, Yvonne, Kathleen, and to all of their families who support us by supporting them, and when they disappear for hours on end at a computer editing pieces of work, and that happens throughout the year. It doesn't stop in sale. I really want to say thank you to you all. And I want to as well acknowledge the work of our board. You've met Katrina, but also Shawnee and Joan and Nesson and what's your name again? Kathleen, is it? For the ongoing support and the willingness to go with it. It's great when the board gets it, and our board get it, and thank you for that. To every one of the participants in SAIL, you're part of us. You're part of it. There'd be no point to SAIL if it wasn't for the women who come and for the kids who come as well. It would be a pointless endeavour, but it isn't a pointless endeavour because we come together and we have fun and we look at difficult things and we look at them brilliantly and bravely. And I think when you are walking outside and you're looking at the photographs, I can't think of a better way of summarising SAIL than those 10 photographs. The honesty and the commitment and the bravery of the women in producing those is something else, and I'd really appreciate that you showed your appreciation for that bravery from the women. And as well, we have great support from the people around us. In this endeavour, we've already mentioned Ballymun Star and Ballyfermot Star and Aris and Coolmine Drug Free Day programme, and we'll repeat them again and again and again because we couldn't have done this work, we couldn't have produced the manual if it wasn't for their involvement. So thank you for that. And to the North Inner City Drug Task Force and all of the projects involved in the North Inner City Drug Task Force, and to Mel and to Miriam, your ongoing support is much appreciated, and your willingness just to be there and encouraging us is great. And to all of the funders, they're listed at the back of RecoverMe, the silent, the quiet ones in the back that again allow us, and to Tom, who I see here, and to anybody from probation who I'm not seeing, but I'm sure you're here somewhere, and to those from the DSP, and it's great to know that support is there. I know you've had to cut us over the years, but today is too nice a day to discuss that. But don't cut us again, or I'm going to set the women on you. RecoverMe isn't just a manual; it's a call to action. In that call to action, it's asking participants to take their recovery onto another level. If you see it, it's feel better, plan better. It's not just about saying, God, I feel, and I'll be aware of those emotions. It's saying, well, let's do things differently. And when I was doing my bit in writing the introductory pieces, I found a quote that I remembered from a song from a long time ago. Well, the 90s. Is that a long time ago? It probably is, yeah. I'm looking at Joan Byrne, it definitely is. By the Indigo Girls, called Watershed. And I kind of wasn't going to put it in, and I was going to put it in, and then Bernie said, put it in, and I put it in, and then I wasn't sure that it fit. But actually, when I was coming here, I realised that it fits perfectly because it captures what RecoverMe is really doing. Because the lyrics go up on the watershed, standing in the fork in the road, or at the fork in the road. There's more than that, but I haven't got them all written down in front of me, and I'm going to go through them slide by slide, so bear with me, we'll get there. But the watershed, standing at a fork in the road, that's where we, working in the field of addiction, we get to meet people at that point in their lives. When people start the recovery process, they're at that point, and it's the most amazing, most honoured place to meet people. At a place where they're deciding to change, where they're becoming aware that change is necessary, and that they're willing to embrace it. It's a most vulnerable spot. It's a most incredible spot to meet people. And then I started thinking, the Indigo Girls were American. Maybe, what's a watershed? And I couldn't work it out. So I looked it up on Google. And to find that a watershed is an area or ridge of land that separates waters flowing into different rivers, basins, or seas. I kind of like that. What made more sense in this context, though, was that it's an event or period marking a turning point in a situation. And that's really what recovery is. It's a period marking a turning point in a situation. It doesn't just happen. You don't just get recovery. When you go from 5 mils to 0 mils, you haven't just got recovery. Because recovery began when you were on 80 mils and you dropped it down to 79 mils. Recovery began when you sat down and said, I wonder, should I be doing something differently? And recovery is that process. And, do you know, being drug-free is a really important goal to have, and it's a really important thing to have. But, you know, I don't know that many people in the world who are drug-free. Drugs are part of every day, and you were all down in coffee before you came in here, just filled with drugs. Drugs are part of our world, and the obsession with drug-free in recovery can be a destructive form. It can be recovery used as a tool to beat clients who are already beaten enough. And I think it's really important that we acknowledge that it's a process of change. It's not almost the death of being drug-free. Imagine that was the way that you described yourself. You know, can you imagine anything more insulting? You know, I am drug-free. You know, no, I'm a dad. I'm funny. I'm part of a great project. I do lots of things. I love music. I love film. I play. I laugh a lot. And I don't use drugs. And if we can't create a recovery that embraces that notion that drug-free is only part of that process, and even when you get drug-free, and congratulations to anybody who does, that you still go for life. Because drug-free on its own is that wonderful phrase that AA have, being a dry drunk. And dry drunk is not recovery. And we, in working in this field, get to meet people at that turning point and to embrace the life that is that change. And part of the life that is that change is also the trauma that is that change. It's a great picture, isn't it? It kind of captures the struggle of ambivalence, that I want to change and I don't want to change, and I want that all at the same time. And whenever you are moving away from something that was enormously part of your life, that change is agony. And what we try to do is what the Indigo Girls are saying: you can stand there and agonize till your agony is your heaviest load. And that's where we meet people, and maybe we can nudge them towards change. Maybe we can help them move on, because if you are trapped in that agony, if there's no place to go, if there's no support, if there's no encouragement, if there's no movement, then all you will feel is pain. And when you have pain, well, then there's need for painkillers. And then maybe relapse, maybe going back down the road that I really want to be on is what will happen. And that's, again, the work of us who are working in addiction, in recovery, is to help people make sure that that agony of worrying about change is not what's going to keep them in that pain. The lyric goes on, "You'll never fly as the crow flies, get used to a country mile." I think in Ireland we understand that better than most. That's a crow flying, by the way. It's just in case you didn't know. And that's a windy road, because recovery is never a straight path. It can't be, because life isn't a straight path. It would be quite boring. I lived in Nigeria for a year, and from Ilorin to New Busa, they had built a road, and it went like that. And it was probably the most dangerous road you were ever on, because it just went like that. Nothing changed. It just went like that. You'd fall off at the end. I fall asleep because nothing was changing, nothing was winding, nothing was turning. Recovery is this winding road, not like the crow flying, like all of Paul's animals. They don't have to think about all of these other things, but recovery you do. And that's what makes it so amazing and so life-giving, because just removing drugs from your life is not recovery enough. Recovery is learning those changes, those ups and downs, the road that has all these turns and the middle way that has to be found in it. The emotions that are in there that I have to now relearn, re-get used to, or learn for the first time in some cases. And we have to get used to that country mile. It's going to take a little bit longer than we thought. And maybe that's the piece. As Melinda, I think it was, saying at the beginning, it feels a long time ago, but Melinda was talking about in the pathways, how it's months and months and months, how cruel we can sometimes be in expecting people in recovery to be drug-free like that. Get it over and done with and move on. 28 days and move on. Go back to work now, it's all done and dusted. No, the process takes so much longer than that. And reflecting that in the way that we work and the way that we meet people in our communities and in the workplaces is really important. I'll just share this one with you, because I like Google and Googling different images and looking around. This is the Stoned Crow pub in Australia. It was the symbol, but I kind of liked it because it captures something of recovery too. We might in recovery have to fly as this crow is flying. But if you look closely at each of those images of the crow, it's made up of tiny little crows all gathered together. And that again is recovery, because you can't do recovery on your own. It has to be together. It has to be part of life with other people. And the thing about it is, when you're learning to face the path at your pace, you're learning something new. The road ahead is unclear. It's terrifying. It's nerve-wracking. Any change can be difficult. But when you're changing something that has been fundamental to your world, maybe for longer than you've been on this planet, have you been using drugs? No, that doesn't work. Longer you've been on drugs than you haven't been on drugs, or longer you've been on alcohol than you haven't been on alcohol, or longer you've worked for sale than you haven't worked for sale. That is a massive change to ask of anybody. And if we don't meet people in that in a way that facilitates the process, then we're missing something. And I believe that what we have in RecoverMe kind of captures that and helps us as workers to be able to slow down the process a little, so that we can stop and work and meet people. So that when we say to somebody, "How are you feeling? How was the week?" and they say grand, or they say fine, they might just be saying it not because they're resistant, or not because they don't want to tell you, but maybe because they don't know how to formulate the answer. Maybe because nobody ever told me how to formulate that answer before. And maybe we need to spend a little bit of time exploring how that might be put together. Because the road ahead is unclear, but what's exciting is that there is a road ahead. And I suppose with that hope is what's going to make the difference. if we can't bring hope in recovery, then we bring nothing at all. Recovery isn't possible without hope. And with that there's a road. Because when you're in addiction, sometimes it doesn't feel like there's a future. It doesn't feel like there's a possibility. But there is. There is a road. But you know what? It's not a racing track road. It's not some kind of station, you know, that I must get to that particular part. It's a road. This is life. This is journey. We don't have to have it all sorted and done and dealt with by yesterday. We just have to do it. And if it takes a while, then it takes a while. And if it takes longer than a while, then it takes longer than a while. We know from research, we know that if you fail too many times, then you start believing you can't do it. And if we set ourselves up for inappropriate, unrealistic tasks, goals, then we won't be able to do it. And then we feel failing. And we as workers, when we're working with people, it's very important that we don't do that. We can take our time. We can slow things down. We can get there. Because the goal is life, not just drug-free, not recovery in the sense of a box that says, we'll tick that, that's been achieved. This is about everybody being better. Recovery is about the whole of the person's life. And that is the family, that is the community, that is everybody around, and making all of that better. And when you rush at that, when you don't do it right, then you end up failing. And then that crushes the individual, it crushes the family, it crushes the community. And we have enough of that. We don't need more. It's a good ringtone, though. I swear to God. Yeah. Owen, can you escort him from the building, please? The lyric ends with, "Every choice is worth your while." I liked this little piece because life is full of choices. And when you are making choices, you need help, you need support, you need your awareness, you need hope, you need safety, you need permission given from the person who's thinking to offer the guidance. You need all those things, but you also need the nudge. You need the "I dare you." You know, you need that encouragement. You need that peace. So as the Indigo Girls say, every choice is worth your while. And I suppose the thing then that struck me was, well, if it's true for them, it's true for us. And you'll excuse the clumsiness of the them and us. But if I can demand that of my clients, of the participants of SAIL, then I have to demand it of ourselves, of me as a worker, as somebody working in the field, me as a manager, me as a funder, me as a counsellor, me as a doctor, me as an outreach worker. If we can't apply these same things to ourselves, if we don't engage in recovery with our clients, and that might not be about drugs, but it's still about that process of life and living, then what are we doing? And in the addiction field in Ireland, in where we're at, we're up on a watershed and we're standing at a fork in the road again. Ireland is in strange place. We're, in many ways, we're being held to ransom by austerity. We're being told what are the ways forward. And what I find difficult with all of that is that I don't have easy answers to offer you, but I can't sit by I can't sit by anymore and look at the way austerity is impacting on the people we work with and say nothing. And I think that we in the addiction field, we have to do that as well, and we have to do it more, because recovery has to be about hope, and it has to be about life, and it has to be about creating a place and an environment where people can come and recover. But if all we do is cut and slash and burn, then the people we work with, some of the most vulnerable people in Ireland today, then all we're doing is creating pain. And when you create pain, as we already mentioned, that needs painkillers. And when you have painkillers, you have relapse, and you have people stuck and staying where they are. I think that's your mother, is it? Yeah. It's probably my mother. There is an agony that's going on when our clients come to our services. There is a pain that's there. We can't just pretend that all that's happening, however necessary, whatever model it fits into. I'm not going to explain any of that because I haven't heard anybody explain it to me particularly well. But if we're really in the business of recovery, if we're really about trying to help our clients find that recovery, then we need to do more than agonize about it. We need to do more than sit back and say how terrible it is. Because when our clients have their medical cards held back, or when they have their CE payments cut, or CE placements cut, or their times cut, and I get the reasons and the thinking behind all those things, but I also need to be able to say that that isn't okay because it's causing agony, and it isn't okay if we're about recovery to be able to, for that to continue. Whenever we work with clients, we know that you can't go as the crow flies. But very often, how we're expected to perform our work is as the crow flies. You know, client in, client out. Have we done the work? And as I say this, I'm not saying it because I don't believe that we should stand over our work and that we should be following best practice, and that we should be, I welcome anybody into SAIL to come in and check that what we're doing is good. And if we're not doing good work, come and help us change it. But I also know that it's a country mile. There are twists and turns with every person that we work with. And that process that Hilda was talking about is absolutely essential in when we're working with our clients. And if that can't happen, then what are we actually creating? Joan Byrne once said to me that on a tombstone there are two figures, the date you were born and the date you died. And the only thing that really matters on that tombstone is the hyphen in between. And that's a bit like when we're working with our clients. The only thing that really matters is not when we started the intervention and when we closed the file. What really matters is the hyphen in between. It's that relationship, that relationality, that space, that giftedness that we can bring that can change without being able to necessarily write it down. Yes, we should write things down. Yes, we must record what we do. Yes, we have to be able to do those things, but there are so many things that we can't write down that are just as valuable. And if we take those away, then our work becomes meaningless. And if we keep living in austerity and we keep taking things away, we won't have room, we won't have space for the hyphen in between. We won't be able to do that piece. And that is hugely concerning. I was going to put up a picture of, you know, when you pick your nails. I'm always picking my nails. Those of you who do it, you pick your nails and you pick them too far, and then it gets all a bit septic and there's all pussy bits. You know, all those. My mother's here. Yeah, I don't. I didn't. Yeah, I couldn't put that up. And my mother's in the audience, so I definitely couldn't. Put your phone off, mother. But imagine that you were sitting with somebody and you had one of those pussy nails and you're in agony. You're sitting there and all you can think about is the pain in your hand. How much empathy, how much compassion, how much presence can you have if that's the case? And unfortunately, I believe that more and more, as austerity is impacting on the addiction field, that I'm beginning to wonder, how can we keep going with the compassion and with the empathy if all of this pain is being visited upon us? The road ahead is unclear. I don't know what it's going to look like, but I do know what I don't want it to look like. I know as well that it's not always happening at my pace, at the pace that I would like. Lots is being imposed. And I know it's being imposed from Europe, and I know it's being imposed by X, Y, and Z, and I know it's also being imposed by political choices. The road ahead is unclear. It will be very unclear if we don't engage, if we don't take part. Life is full of choices. Choose to be happy, choose to be strong, choose